move on to our next talk, titled How to Empower Women in India to Make Their Health Decisions by Dr. Christianez Ratna Kiruba, and I invite Dr. Sowmya Sathyendra to chair the session.
Thank you, Jennifer, and it's my pleasure to introduce my student, uh, Christianez. And just to give a brief background to what I know, so Christianez, of course, studied in CMC, undergraduation and post-graduation. And right now she's serving in a rural hospital in Assam. And what I know about Christianez she will be the right person to do an advocacy talk, and she has interests in patient advocacy, empowering women to make their own decisions is what she's going to talk about. But that's something that is very close to our heart. She's also written many articles on this subject, and her other areas of interest include medical ethics, universal healthcare, and medical writing. So I'd like to invite Christianez to please go ahead, and thank you so much for being here.
Talk is about how. Good afternoon, everyone. So my talk is about how we can empower women in India to make their own health decisions. Now, so let's look at the layers of the problem first. So, with a show of hands, can you tell me if you have ever heard or said any of these sentences in your practice? Wait, doctor, can you explain this to my husband or brother or father instead? I need to discuss this with the men at home. They will tell me what decision I must make. Can you call any of the male relatives? I need to discuss the patient's condition and finances. So, this is quite a widespread problem. And so, there are many reports regarding the problem. We see that 80% of Indian women need to take permission from some family member before which they can even access healthcare services by going to health centers. Even in decisions that are unique to women, such as contraceptive decisions, which it must not be. However, in India, it is a woman's burden. Even in such decisions, women have to take permission and they do not have adequate access to healthcare. And so, surrogate decision making is when somebody else makes decisions for somebody who is mentally ill, in keeping with what they assume their wishes might be. However, in India, surrogate decision making regularly happens for women who are competent enough to consent and choose during things like childbirth. So, it's a really huge issue. And this issue shows up in our practice in bizarre and sometimes heartbreaking ways, like people having to counsel next door neighbors of a patient regarding their prognosis just because all the next of kin are women, about seeing women in labor asking for epidural or pain medicine and then having their husbands and mother-in-laws refuse that, and then we see the women go through the pain that they did not consent to go through. Or even if when women find themselves in a position to make decisions like mothers or wives of patients, and you're going to them and saying, can you sign this consent form for intubation, they are like, okay, wait, let me call some male relative. And then, they are hesitant to make decisions even when they find themselves in a place where they need to make decisions. So in 2012, when I joined medicine, when I joined MBBS, this was the movie that was shown to me to explain medical ethics. It follows an English professor who's a patient of ovarian cancer, how she receives the diagnosis. She decides to sign up to be a part of an experimental treatment. And so she makes all these decisions by herself. Eventually, she signs a do not resuscitate, and how that gets followed. So we get this idea when we learn medical ethics that we have all these rights, and then we go out into practice, and then you find that there is a large gap translating what we learn about medical ethics into practice. So when we talk about autonomy, what is autonomy? Autonomy in the medical context says that any individual has the sovereign right to decide what happens with their own body. And jumping off of that, we have this concept of informed consent, where a patient needs to consent to things that need to be done for them. However, so in practical setting, what is an empowered woman? Am I an empowered woman? Are you? Is Lakshmi, who comes to your OPD, an empowered woman? So a very reductionist way of thinking about empowerment of women is education. We all think education equals empowerment. However, all the studies across the board on autonomy say that even women who are very well educated do not have much autonomy of making decisions. So actual indicators of autonomy are a few things like financial independence. Does she have a job? Is she salaried in that job? Is that salary being given to her in her hand or to a family member? Does she have an account which she operates individually? Secondly, is mobility. Does the woman have the mobility to go where she wants, when she wants, without asking for permission, or does she need to be accompanied? And then intra household decision making, like how much decisions can she make even about small things like what to buy, what groceries to buy. These are things that actually translate into autonomy for women. And unless education translates into these, like unless education becomes employment and then becomes financial independence, education is not really contributing to autonomy. So other thing is cultural setup. Now, individual autonomy is what we usually talk about. It's practiced in Western countries. Individual decides how much involvement they want from families, and then so the decisions that are being made are what is best for the individual. However, in India, we practice collective autonomy, where the family unit, in fact, decides everything. Most decisions are taken with consideration to the family unit, and eventually it's going to be a decision that's best for everybody in the family. Now, in this context, one could argue that even men don't have that much autonomy in India as much as somebody would have in Western countries. Now, moving on to the next layer, this is a quote from one of my friends. She says that anytime she explains breastfeeding options or reproductive choices to women, they always say it's not their own decision to make, it's always a family decision. Now, family decision is a label that gets tacked on to everything that, uh, everything, all the decisions that need to be made about women, starting from their birth, it always tends to be a family decision. So, home is actually where the hurt is, by which I mean that nobody oppresses a woman more than her own family members and loved ones. In many families, men control the cash flow, they hold the purse strings, and hence they can make more decisions about what happens to any of their family members. In joint family structures, there are also hierarchical family dynamics. Um, so, for this, I read a study. The study was called The Curse of the Mummiji, which meant that the mother in law has more say over what happens to a woman than even the husband, for that matter. So, and then there is this thing called collusion. What is collusion? Collusion is when a patient's relatives come to the doctor and tell them, I don't think the patient can handle this information. So we will collude or cooperate between each other and lie to the patient or withhold information about the patient's condition to them. And this happens quite often when the patient in question is a woman. Now, when I was in ICU, I was posted in ICU during COVID times. I had a hematology patient. The patient had come with severe COVID ARDS, was intubated, and eventually passed away overnight. So we gave a call. At that time, the institution was not handing over the bodies back to the family. So we used to call relatives to come in and see the patient one last time. So when we gave the call, the person holding the mobile was some distant male relative. From him, we found out that this guy actually has a wife. And this person told me, we don't know how she's going to handle the information. You dispose of the body, we'll tell her slowly. In the middle of the night, I'm just standing there, heartbroken at the idea that some woman out there is not going to ever get to see her husband again, not even one last time, just because some family member decided that women can't handle truth. Secondly, women themselves, they think their opinions and preferences have no value. And how would they? They have spent all their life being told that their opinions have no value. And they do not realize that health decision making for themselves is their right. In a survey done by Maternal Health Task Force, 90% of the women interviewed said that it mattered to them how their birthing process went, but 36% of those women did not even communicate their preferences, not to anyone, not to the healthcare provider, or not even to their family members. Women tend to undervalue what they feel and what they think. So, all these inequalities exist out in the society, but a system, how it exists, can either amplify or mitigate these inequalities, and unfortunately, Indian healthcare system amplifies it. And how do we do that? Firstly, not enough information. Even we as healthcare providers have somehow decided that our women are not able to handle information. Firstly, studies say that even when we take informed consent forms, only a portion of women actually understand what is going to happen in these procedures, and they don't understand the complications of what is going to happen in these procedures. They are not explained well. Only a portion of women receive comprehensive information about all the options that are available to them. As healthcare providers, we also sometimes tend to push what we think is right, what option they must choose. They do not, they're not aware of all the options that are available to them. And many doctors end up not speaking to the female patient or the bystander. And we are busy, right? We don't want to talk to them twice. Like if you talk to the woman, you know that you're going to have to talk to a male person again. And that somehow is what a doctor thinks. They want to use their time efficiently. And however, because of that, our women are not ending up with information. And pollution, as I said, is significantly higher if the patient is a woman. Secondly, our own biases. Now, outside, at least doctors ask for spousal consent in procedures that do not require the same, like abortions and contraceptive prescriptions. The way we give reproductive health care to our women do not follow any principles of reproductive justice. And so, this is another thing. If I could have a time machine and go back to meet myself in internship, this is what I would say. When you are trainee doctors and then you're in labor room and you see a 15-year-old pregnant woman, or you see a woman who cries when she has given birth to a daughter, like you'll just bristle, you'll burn with incandescent rage, or I did so. And then you would shout at the woman. You would be like, how can you say this? Women are doing such great things out there. But what she's saying is an indicator of what she has, her problems, her lack of privilege. Now, where I practice, when I ask a woman, like, who is this person? And if that's her husband, sometimes she said, ye mera malik hai. Malik hai meaning owner. That's how they talk. Now, I can either again tell her how like she's not an object to be owned, and in that process distance myself from her, ruin our therapeutic relationship, and ensure that she never comes back to me again. Or now I just stop myself. I tell myself that if I was born 50 years ago or 50 kilometers away from where I was born, I could be in her place. So I don't want to widen the gap. I have had to learn a lot to ensure that I don't put the responsibility of victimhood back on the shoulders of that woman. And if there are medical students out here, please don't make my mistake. And our medical curriculum is sorely lacking in provisions as to how we have to handle these complicated scenarios in our day to day practice. We learn westernized medical ethics, which is not culturally appropriate for our Indian context, and that has to change. But why is female autonomy important? It's a moral imperative. No matter what numbers I am going to give you further down the line, does not matter. It's a moral imperative that anybody who's availing health gets to decide what's going to happen with their own bodies. However, NFHS 4 data suggests that for women with higher autonomy, they tended to have full antenatal care, they had institutional births and good postnatal care as compared to women with lower autonomy. A study done in 12 countries, mostly Southeast Asian and Sub-Saharan African countries, showed that women who made decisions about their children tended to have higher immunization rates, lesser child mortality, and lesser child malnutrition. Data also suggests that women who make intra-household decisions, they allot more resources towards their own care as well as for their children as compared to men-run households. So, across the board, studies suggest that increased female autonomy leads to better health outcomes for women and children. So, the question, can women make good decisions for themselves? Of course, there are so many studies that say that women make great decisions for themselves and their kids when given a chance. It's just that our women need to know that. So, solutions. Now, the solutions can be at the level of an individual physician, at the level of the healthcare system, and at the level of the government. I'm going to try and focus more on the level of the individual physician, but because I have not done any work in the community regarding this. So, with what I know, I can only, with authority, talk about what we can do as individual physicians. And when I also hear a lot of community level or government level solutions, I feel helpless. So I would want you to leave my talk feeling a little bit like you can make a difference by just yourself. So at physician level, you have to educate yourself on the principles of healthcare and reproductive justice, some of which we do get exposed to during our medical education. Secondly, unlearn biases. So there is a quiz, I think by Harvard, which when you take, it shows you what biases you have. And I have been a self proclaimed feminist all my life. I took that quiz which says, do you have biases of men towards work and women towards family? And lo and behold, it was very funny when I got the report. And I did have that bias, being a feminist all my life. So we all have hidden biases. It's very imperative that we learn what it is and then try to unlearn them all our life. We attain cultural competence, which is we need to understand both the language as well as the structures and the prevailing beliefs in the community that we serve in order to serve them better. Like our solutions to their problems cannot be at odds with what they believe to be good for themselves. We have to ensure, and this will be like, at this point you'd be like, Christianez, this is a lot of work. I don't want to speak 2-3 times to people. However, that is something that you have to do. You have to ensure that all the information should reach the patient as well as the bystander, even if you know 100% they are not going to make that decision. At least letting them know what is available for them is important. We need to learn to ask about concerns and preferences because, as I said, many people don't talk about it. Asking them multiple times to understand what their concerns and preferences may be is important. And this is the most important part. If the woman says, I want this, her family is not going to listen. But you are in a unique position where you can advocate for your patient, where you can amplify her voice. When you say it, they're going to listen. And that is really important. So I know that what we want in the long term is for the woman to be able to advocate for herself, but that is a marathon. This is this in the short term, advocating for your patient and communicating her preferences to the relatives can really help. Now, at the healthcare system level, image and video based informed consent tools in local languages are really important to ensure that people understand what treatments they are agreeing to. Female counselors and translators to ensure good communication, and context specific medical ethics classes need to be included in medical education, and gender sensitivity training. Now, social methods. As a woman, and as many women, like, we see that what is limiting us is our social relationships. We all want to be liked. Usually, and the difficulty with accepting new interventions also, people will say that our family reputation will go, things like that. Social acceptance is really important in the Indian community. So this is a study where family planning was proposed to women, and they were given vouchers and asked to bring somebody who is not their husband or their mother-in-law with them. And it could be another woman who also wants to avail family planning services. In this way, not only did the woman actually make friends outside her immediate family, she developed social networks and social support, but also she was able to uh, show her family members that it's a socially acceptable thing. See, another peer of my age is also availing family planning. So it's a socially acceptable thing. Your reputation is not at stake. So this showed that women who brought these vouchers and brought a friend actually tended to avail modern contraceptive methods around 45% more than women who did not, or women who came with family. And secondly, family planning is another difficult thing because there is misalignment in fertility preferences within the same family. Like, what a mother-in-law would want and what a woman would want would be completely different. So convincing the mother-in-law is really important because we bring very good accessible solutions to their doorstep, but we don't engage all the stakeholders. And a woman, in fact, arguably, a rural woman, more than her husband, a mother-in-law plays more of a role in what decisions she will make. And so engaging other family members and stakeholders is really important. Government level solution, and this is a great success story of the Rajasthan Nutrition Project. Now, Rajasthan Nutrition Project was introduced because Rajasthan was one of the most food insecure states in terms of women and children. So, what they did was they used existing self help groups and then taught them and made women competent about providing nutrition to their own family. If I have less money, what should I buy? How do I cook? How much should I give my child? Things like that were being taught. And these, alongside that, they also had gender dialogues about, you know, the fact that women are competent and that they should be able to make these intra household decisions, etc. Now, Rajasthan Nutrition Project itself improved food security in Rajasthan. It also increased the number of children who were being breastfed in the first hour. It also improved the fact that children were being given ORS if they had acute gastroenteritis. However, it had a very interesting after effect which was studied. It improved women's autonomy. So, making them competent to make decisions, telling them that they can make decisions, ensure that women actually participate in decisions. So when we see that they are hesitant in making health decisions, we don't have to give up saying that, we are only going to face resistance. We need to make them believe that they are competent enough to make decisions. Like, active participation has increased in, say, for example, food related decisions from 24 to 48%. But if you see, another thing, husband alone making decisions fell from 30.8 to 3.2. So even if women are not solely making decisions, they're at least saying something. They're making shared decisions. And even that is a great goal to aim towards, for them to feel like they have a say. So the other thing is self-help groups. Existence of self-help groups help women have a little bit of financial independence, and when they make decisions and they see that they're competent enough to make decisions, they continue to empower themselves. So what I would like for all of us to realize is that when we talk about access, stocking shelves and um, having trained professionals to deliver healthcare is a very narrow definition of access. Is it really access if a woman comes to a shop and does not get to decide what healthcare comes to a healthcare center and does not get to decide what healthcare she would like to avail? Or is it really access if, like, a woman goes to labor room and then wants to avail an institutional delivery and then undergoes dehumanizing, disrespectful care? Is she ever going to come back? So I would like us to widen our definitions of access and say that access also depends on autonomy. And unless the person who's accessing healthcare doesn't have the autonomy to decide what they want, access is incomplete. And this is the references for my presentation. Thank you.
Thank you so much, Christianez. I think it was just a capsule of your journey through this whole process where you as a woman also realized how empowerment can work for yourself and for the others. There's one comment on the chat which already says they have actually thanked you for it, saying it's a very rich talk and they learned from your experiences. So that is a comment from here. Can I have any comments or questions from the audience? Please go ahead.
Good afternoon. It was a very interesting presentation. I really like the way you put it up. I am a physician from Pondicherry. I work in a private medical college. So not to contradict or just another end of the spectrum, which I had to witness probably a few months ago. So this is actually a story, since it was a little long, I couldn't put it up in a paper. So I had to encounter one of my friend's mother had a history of incisional hernia, which she actually did not want to operate for a very long time. And then, so the thing is, she is a very headstrong, a single mother, a headstrong woman, a very independent, otherwise, a I would say, who was able to take decisions for her own. So the thing was, she had history features of obstruction, in the sense she had history of vomiting, uh, constipation for a while, and then she was actually reluctant to even show the abdomen to me for a while. So since she had she's a 60 plus mother, and since she had a history of visiting a few doctors whom she relied on, and this was a conventional practice that she had. She wanted to get an appointment to this particular male doctor, and she was refusing to show the abdomen to me also. And then finally, when she got she got a consult or appointment with the practitioner whom she was trusting for a while. He had advised that it looked like obstructed hernia and she had to get operated immediately. Now the thing is, this mother already had certain outlook towards her life, that she's towards the fag end of her life, and then she does not want to go to a doctor. Probably she can go the next day when her elder son has to come from Bangalore. So she's like, okay, let the elder son come. And also, this is a mother who has certain perspectives or outlooks towards her own health, and she also has an amount of trust towards a male child in the family. So the thing is, so I had to, because my friend called me, I had to just go and see her in the night. And so I was in a dilemma whether to overrule her autonomy, pull the trump card and just talk to the elder brother who is pretty educated. So he went online, searched about obstructed incisional hernia, and then he was like, okay, it has to be attended to immediately. So then I had to, I tried convincing, because she's in good terms with me also. So I tried to convince her over a long amount of time, but then I couldn't. And since it was kind of like a health hazard to herself, I had to play the trump card, call the elder son. And then he did the convincing. And then finally she had to, I mean, she came and got consulted and immediately got herself operated. So the thing is, at times, even though I would say women have the autonomy, thing is there are a lot of misinformation, plus a lot of probably a lot of traditional outlooks towards health, where sometimes you will have to, since traditionally, right now, I mean, even though women are educated, we would have some male figure in the family who is a little more educated, and then we would have to explain it to the male figure, and probably, kind of like halfway autonomy to the woman. And then because there is a better, way of communicating or making her understand, I would say, I mean, at this experience that I had, I was in a dilemma whether to, overrule her autonomy. And then, yeah, because her health was at risk, I had to make a male attender convince her who was better informed. Yeah, so that was an experience I had. Thank you.
Thank you for sharing that. Christian, any comments on that?
Okay, I will tell you a similar personal experience. This is about my mother-in-law. So she had general body aches and stuff, and went to multiple orthopedicians, did not get diagnosed. I suspected postmenopausal osteoporosis, and bone mineral density scan eventually showed that. So I made this awesome decision of supplementing vitamin D and start bisphosphonates. After the bisphosphonates, kind of you get this influenza-like symptoms. I had told her that she would get it, but then when she got it, she realized it was very severe. And by that time, she had decided that she wanted to show a different doctor. So at this point, like I have seen that so many people she has gone to who has not even made the diagnosis. And those are the practitioners she wants to go back to. Now, do I respect her autonomy, or do I say that, like, we are a medical background couple, like her son is also a doctor. So do we say that, like, no, we know better, you have to listen to us? So it was a very interesting place to be in. She even said things to me that I would tell my female patients, like, you have to advocate for yourself. You should tell your doctor, this is my body, I have lived with it. What do you know? And then she says that back to me. So it was a very funny and interesting place. But then, as a couple, we decided her autonomy is important. So we took her to those same doctors. We just ensured to stay with her so that we know that she's not being taken for a ride. And then, yeah, so now they have suggested teriparatide, which is a subcutaneous injection. Mom-in-law is losing it at the idea of receiving subcutaneous injections every day. But we have at this point decided that it's she who's going to get those injections. I can tell her that she won't get a fracture further down the line, but if she doesn't think it's worth it to get injections every day, then who am I to force her? Or who are we to force her, even though we are better informed people? Like, it's her life, it's her decision, and in the end, it's her body. And that, in her words, it's her body and it's her decision. So we cannot do anything. So even though we are better educated.
I just thank you for that, Christianez. I think that was a combination of autonomy and mummy G. So, Christianez, can you wait? Can you wait, please? I think Divya wanted to ask you a question. We just have a few more minutes, so please go ahead. Please go ahead, Divya.
Yes, to bring gender into it at all. We would have done it the other way too. If you had a male patient who had an obstructed hernia and required surgery, and you thought his wife had sway over him, and you had tried and you thought it was a health hazard, you would probably involve his wife to talk to him and maybe come to a decision together. So It may not have been, it was just that there was a relative. Okay, in this particular case, it was her son, but it can go the other way also. So obviously, when there's a health hazard involved, you talk to people such that in the best interest of the patient, something happens. Maybe you don't need to bring anything to do with gender in it.
Thank you, Divya. There's one more. There are two more questions. After that, Dr. Sarah will be giving a comment. Please go ahead.
Okay, so just continuing the Mamiji perspective from a pediatrician's viewpoint. So I realized that when we even use the term genetic disease, somehow it gets always, although the genes come from both the dad and mom, somehow it always tends to be blamed on the. So I had a 1.5-month-old infant who presented severe diabetic ketoacidosis, very life-threatening condition. We are treating, child got better, and when for some reason they decided to blame the mother and that it is something wrong with her, maybe it is the breast milk she is producing, and I had this conversation with the mother-in-law and the father and the mother, but it had to be repeated at least once or twice more. This mother was like absolutely shattered. The kid got better, but even then she was absolutely shattered, and we had to have this conversation 2-3 times. So I think even that is something that we need to keep in mind. Even using the word genetic, we need to explain it completely. Thank you.
Christianez, anything to add to that?
Yeah, joint family structures by their very nature are they cater into the patriarchal rule. So kind of like um, the guy, his family, everybody is there. He gets all the social support he needs, and then there's this woman who comes into this and then has to give up everything as she has known it, and has to completely change, adjust into that new system where she has no social support. Like where if anything goes wrong, like everybody is going to rally around the man. Like the woman is going to be completely alone, and most of our women are incapable of fighting their own battles. Like parents themselves silence them and say कि ससुराल में जाके ऐसे बात करेगा तो मार पड़ेगा. So I agree. Like if they bring in family members from their marital homes, then we have to be extremely sensitive. Like we have to understand that the woman is not going to be really supported out there.
Thank you, Christianez. Dr. Sarah.
Yeah, thanks so much for what you presented, because it's a very difficult area. And because society is still so rooted in patriarchy, we don't see it. Neither do the women see it, nor do the men see it. So highlighting it is extremely, extremely important. What is hopeful, I think, is that more and more people are beginning to see it, and that we keep it in mind, and remember that we have to address both the men and the women, because society will not change unless both are addressed. And from my own experience with women, both in the rural and urban areas, if you can collectivize them, there's a lot of power. So I think that's a very important way to go forward. Thank you very much.
Thank you, ma'am. I think, unfortunately, we look at it as a battle of the sexes rather than, a collective decision to move forward. And that's the valuable part here. Are there any other comments? Just, yeah. Yeah, we can have these two comments, and then I'm sorry, I'll have to close after that. Yes, please.
I would like to put forth an experience. I'd like to put forth an experience again because we had a couple which was just married about 4 to 5 months ago, and the female came with us with the complaints of pedal edema and breathlessness, and we had to admit her and we diagnosed her of rheumatic heart disease. And now, while we were counseling the family that this is a case of heart disease and uh, probably she might have had symptoms before, but she was not evaluated to the extent that she got diagnosed. But this is the first time we could diagnose her. So there was several question marks on the family of the husband, and they came to ask us repeatedly that is it possible that the family of the girl had come to know of this disease before marriage, and they did not inform us about it. we were not in a position to actually, assure them or say something else. We just talked to the girl, and she repeatedly denied the fact that she had symptoms of breathlessness or anything else related to heart failure before. But the issue got extended to such further that the husband's family stopped visiting his wife during the stay of the hospital, and it become a major issue for us. First place, that who will take care of her, and second place, who will bear the expenses, because the earning members of the husband family, they stopped coming completely to the hospital, and they had given up. So the stay of the female got extended by a few days just because they were not able to bring money. So even in the follow-up visits, we saw that it was her mother who is to take her, and probably they had given all hope that the husband family would finally accept her.
Thank you for sharing that. There's one more comment at the back, and then we'll.
Ma'am, I would like
Oh,
to
sorry.
just
I'm
say
so sorry.
something.
Please
So
go ahead,
what you
Christianez.
have pointed out, I have also written about in an article of mine called Raised for Captivity. So this is a paradox, right? Like parents raise children with females and then they treat them like liabilities. They say, I'll get you married off and then I can take a breath and then I will be off your this. But what happens after the girl gets married off? Like she gets pregnant, goes back to home, gets sick, goes back to home. Anything happens, her birth family gets called. And in the interim period, she's also not very capable of handling herself. So both of this, it's like some weird pass the parcel that the birth family and marital home keep doing with this girl. It's a paradox. Like who's secure? Like we say, we propose marriage to women saying that this is the only way you will be secure, but they're not secure in their marital homes. They get beaten up, they get like if they are sick they get sent back home. So who's being secure? I don't understand that, but that is the paradox that exists in society. The existing belief is that birth family, once they marry off the woman, she will be the marital home's headache, and marital home thinks that whatever something happens, I will send her back home to the birth family. So it's weird.
Please go ahead.
You said raised for captivity. Suddenly, I realized that crystallized everything that I had in my mind. I'm a psychiatrist practicing in a rural Tamil Nadu. My job, dubious distinction of breaking all love affairs. That is my job. I have to counsel them, break all the relationship if I can. Unfortunately, it doesn't work. We know what it doesn't work. And what happened to my distress that I have seen is very highly qualified girls who can live on their own if they want to are held captive. Their phones are taken off, who have been working so far, and they can't have access to bank or money or anything. And what is my role? I have to be very carefully treading and say, please give back her phone. No, she'll talk to the boy, and all our cultural or whatever, izzat or whatever you call it, will be down the drain. At the same time, I see girls who have nothing to lose, who would have had just a +2 education, will take it on in their hands and try to have a life. And these are really raised for captivity. True. Thank you.
Thank you, ma'am. And just to again thank you. I think you showed it in your life in terms of obviously in your situation in the family, your husband was involved in the discussion, and together you went on to give the autonomy to your mother-in-law. I just want to add a comment that unfortunately for our women, the only time they get power is when they become a mamiji. So that's the time they're allowed to dictate terms. So in a way, we have to balance how much we take away from the mamiji and add to the woman, and then get, move forward. So thank you so much.
Completely understand that. That is the one thing I am against vilification of mother-in-laws as a whole. They have been oppressed women themselves in life. The entire life, they never had any agency. The only person they said they were allowed to control is a daughter-in-law, and they've been waiting for it, poor things.
Not a life. So that's just a balance when we put all the mummijis into a group. And I think I've also personally, as having one, being conscious of the effort to say that there are other situations which is larger. So thank you so much, Christianez, and thank you all for your discussion.
Thank you for that talk, Dr. Christianez. I request Dr. Sowmya to present over the memento.